Pigmented lesions of the conjunctiva. I have no financial disclosures relevant to this presentation. Primary melanocytic lesions of the conjunctiva include nevi, congenital ocular melanocytosis, freckles or aphelidades, complexion-associated melanosis, intraepithelial melanocytic lesions with or without atypia, and conjunctival melanoma. Many conjunctival nevi are excised from teenagers because they often enlarge and become more pigmented during puberty, as seen in these photos. Most conjunctival nevi are located on the bulbar conjunctiva near the limbus, or in the plica semilunaris. Nevi of the tarsal conjunctiva are quite rare. Conjunctival nevi can vary markedly in their pigment content. They include amelanotic nevi that are pink or tan in color, lightly pigmented nevi, moderately pigmented nevi, and darkly pigmented nevi. Histopathologically, conjunctival nevi are classified as junctional, compound, and subepithelial. In junctional nevi, which are rare, the nevus cells are confined to the epithelial-subepithelial junction, and the underlying subepithelial stroma is uninvolved. Compound nevi are most common. About 2/3 of conjunctival nevi are compound. Compound nevi have both a junctional and subepithelial component. In subepithelial nevi, the nevus cells are confined to the subepithelial stroma, and junctional activity is absent. Subepithelial nevi have no malignant potential, which resides in the junctional component. Subepithelial nevi are common in older patients because the junctional component diminishes with age and is lost. The German dermatopathologist Paul Unna called this process Abtrüffung, a German word meaning dropping down. Nevi in adults typically have little or no residual junctional activity. Therefore, a purely junctional nevus or significant junctional activity in an adult is worrisome and should be considered to be primary acquired melanosis, an extremely important precursor for conjunctival melanoma until proven otherwise. Cysts are a characteristic feature in conjunctival nevi. More than 60% of conjunctival nevi contain cystic or solid rests of surface epithelium. These cysts are a helpful clinical marker for nevi, but they don't totally exclude the presence of melanoma because melanomas can arise from nevi. The cysts in nevi typically enlarge with age. These photos show large cysts in a predominantly subepithelial compound cystic nevus excised from a 54-year-old man. Inflamed nevi of puberty may have disturbing atypical histopathologic features, shown here in this photomicrograph. This case had spindle cells and atypical mitotic figures, shown under higher magnification in the inset. However, malignant melanoma is rare in childhood, and the rate of malignant transformation of nevi to melanoma is less than 1%. I typically diagnose such cases as inflamed nevi with severe atypia, and I recommend total excision and careful follow-up. Blue nevi occasionally occur in the conjunctiva. They are composed of melanocytes of neural crest origin that become arrested during the course of embryonic migration to the surface epithelium. Simple blue nevi are composed of pigmented spindle cells with a wavy dendritiform configuration that are located in the substantia propria or dermis. Nevi composed of a mixture of typical nevocellular nevus cells and spindle cells resembling those found in blue nevi are called combined nevi. The pigmented blemishes that occur in congenital ocular and oculodermal melanocytosis of the nevus of Oda are composed of spindled and dendritiform melanocytes located in the epibulbar tissues. The deeply situated pigment does not move with the conjunctiva and appears blue or slate gray due to the Tyndall effect as light passes through the overlying substantia propria and epithelium. In the left part of this photo, the epibulbar pigment appears brown where it is exposed by a rip in the conjunctiva. Seen through intact conjunctiva at right, the pigment has a characteristic slate gray appearance. Nevus iota does not predispose to conjunctival melanoma. An associated nevus of the uveal tract predisposes Caucasian patients to uveal malignant melanoma. Their estimated risk of developing a uveal melanoma is 1 in 400. In addition, they have a twofold greater risk of developing metastatic disease. A spectrum of pigmented lesions involves the conjunctival epithelium. These include constitutional or complexion-associated melanosis, freckles, reactive melanocytic proliferation, and neoplastic melanocytic proliferation, with or without atypia, that's typically called primary acquired melanosis. Full thickness replacement of the epithelium by atypical cells is called melanoma in situ, and this can eventuate in invasive malignant melanoma. Constitutional or complexion-associated melanosis, previously called racial melanosis, is a benign condition that occurs in heavily pigmented individuals and typically affects both eyes. Histopathologically, the melanin pigment is present within the squamous epithelial cells of the conjunctiva, and significant melanocytic hyperplasia is not present. The pigment may involve the entire thickness of the epithelium, where it often forms umbrella-like apical caps in the most superficial layers that presumably shade and protect the nuclei. Care must be taken when assessing pigmented lesions in heavily pigmented individuals, as they are not immune to malignant melanocytic neoplasms. Atypical melanocytic hyperplasia has been misinterpreted clinically as complexion-associated melanosis in some cases. This African American woman developed a large malignant melanoma of the conjunctiva that arose from PAM with severe atypia. The thoroughly ingrained term primary acquired melanosis, or PAM, has been applied to an important spectrum of conjunctival epithelial pigmented lesions that involves varying degrees of intraepithelial melanocytic proliferation. The pigmentation of squamous epithelial cells found in complexion-associated melanosis comprises the benign end of the spectrum and has been termed hypermelanosis by some. In the 2018 WHO classification of tumors of the eye, primary acquired melanosis is termed CMIL, or conjunctival intraepithelial melanocytic lesion. Other terms proposed previously for this disease spectrum include CMIN, or conjunctival intraepithelial neoplasia, and IMP, or intraepithelial melanocytic proliferation. Primary acquired melanosis is characterized by the proliferation of atypical melanocytes within the conjunctival epithelium. The condition is unilateral and typically affects middle-aged or elderly Caucasian patients. The pigmentation has an insidious onset and often waxes and wanes. It is brown in color and moves with the conjunctiva because it is located within the epithelium. Primary acquired melanosis with atypia is a major precursor for conjunctival malignant melanoma. Varying degrees of intraepithelial atypical melanocytic hyperplasia occur in this disease spectrum. These photomicrographs show examples of PAM with mild atypia, PAM with moderate atypia, and PAM with severe atypia. Histopathologic features in cases of PAM with atypia that predict progression to melanoma include the presence of atypical melanocytes that are not confined to the basal part of the epithelium and the presence of epithelioid melanocytes. Pagetoid spread and nests of melanocytes are other factors associated with poor prognosis. Prognosis is better if the melanocytes are confined to the basal epithelium in a lentiginous pattern. Many call total replacement of the epithelium melanoma in situ. PAM with atypia is an important precursor of invasive conjunctival melanoma. About 75% of conjunctival melanomas arise from PAM with atypia when the atypical melanocytes breach the epithelial basement membrane and a vertical growth phase of invasive melanoma ensues. Conjunctival melanoma is relatively rare. It is 1/10 as common as uveal melanoma, and its mortality rate of 26%, while significant, is half that of its uveal counterpart. Conjunctival melanoma is more similar to cutaneous melanoma than uveal melanoma. It metastasizes to lymph nodes, not to the liver like uveal melanoma. And some conjunctival melanomas have BRAF mutations, which are absent in uveal tumors and can be treated with targeted therapy. Extralimbal location and positive surgical margins are factors associated with poor prognosis. When assessing a pigmented conjunctival lesion, the pathologist must answer several questions. Is the pigment contained within squamous epithelial cells or within melanocytes? Is there an increased number of melanocytes? Are the melanocytes atypical? Where are the atypical melanocytes located? Are they confined to the basal epithelium? Or do they involve more superficial layers? Have they extended into the substantia propria as a vertical growth phase of invasive melanoma? We have found that immunohistochemistry is a helpful adjunct in the assessment of these lesions. Stains that we commonly use to assess melanocytic lesions are listed here. They include melanocytic markers, Melanoma and SOX10, melanoma-specific antigen, HMB45, proliferation marker, Ki67, and the newly available marker, PRAME or PRAME. Immunohistochemical stains for melanocytic markers like Melanoma and SOX10 confirm that lesions are melanocytic and can disclose the presence, extent, and location of melanocytic hyperplasia that may be inconspicuous in routine H&E stained sections of amelanotic lesions. The use of red chromogen is recommended during the immunohistochemical assessment of melanocytic lesions. In contrast to the brown reaction product of the standard chromogen, the red precipitate is readily distinguishable from endogenous melanin pigment that is present in many melanocytic lesions. These photos show extensive replacement of the epithelium by atypical melanocytes in a case of PAM with severe atypia. In contrast, these photos of complexion-associated melanosis show that the pigment is present within the epithelial cells and no melanocytic hyperplasia is present. Red staining by SOX10 denotes a single melanocyte in the basal cell layer. Immunohistochemistry also provides clues that help to differentiate between nevi and melanomas. A melanoma arising from a nevus is shown in these photos. These photos show that both the nevus and the melanoma stain intensely with melanocytic marker Melanoma. At bottom left, we see that the melanoma stains positively with melanoma marker HMB45, but the nevus does not stain. HMB45 typically is negative in the middle and lower subepithelial components of nevi, but it may be weakly positive in the superficial junctional zone. The Ki67 proliferation marker shows significant cellular cycling within the melanoma, which is absent in the nevus. The red nuclear stain also highlights the presence of enlarged atypical nuclei. The lymphocytoid subepithelial nevus in these photos stains intensely with Melanoma, but is negative for HMB45 and Ki67. It was also negative for PRAME, a newly available stain that appears to be a promising marker for malignant melanocytic lesions. PRAME stands for Preferentially Expressed Antigen in Melanoma. PRAME may be the magic bullet to detect melanocytic malignancy. Other pigmented lesions of the conjunctiva include pigmented squamous cell tumors, systemic diseases like Addison's disease and ochronosis, drug deposits such as epinephrine, tetracycline, and arginol, tattoos, cosmetics like mascara and kohl, pigmented mycotomas, and metastatic cutaneous melanoma. Squamous cell neoplasms in pigmented individuals may be significantly pigmented due to a reactive proliferation of benign melanocytes. This is a pigmented squamous cell carcinoma in an African American woman. The histopathology shows the characteristic abrupt transition between the tumor above and the normal conjunctival epithelium below. Higher magnification shows scattered reactive melanocytes within the tumor that are responsible for its pigmented appearance. Brown deposits of ochronosis typically are found anterior to the insertion of rectus muscles in patients with alkaptonuria. Chronic instillation of silver-containing medications like arginol can cause grayish pigmentation of the conjunctiva. Accidental or intentional tattooing can cause conjunctival pigmentation. This case was a miner who was injured in a coal mine explosion. This bizarre photo shows cosmetic tattooing of the conjunctiva performed by a tattoo artist. This pigmented lesion is a mycetoma that developed after a woman injured her eye in a rose garden. Here we see the mass of pigmented hyphae forming the mycetoma. The final case is a patient with advanced cutaneous melanoma that metastasized to the conjunctiva. The metastatic melanoma is growing within lymphatic channels in the substantia propria. Thank you for your attention.